This conference will now be recorded.
Okay, so all of you, welcome to class. So this is the second class for ovarian cancer, and in this class, I have compiled a lot of things. So related to only exam or purpose, both helpful for part 2 people and also for the part 3 people. So from the NICE and also from the talks and also from the guideline, okay? And lots of questions are there, so that I try to put so many talks and many things together. So coming to class now, epithelial tumors are these are the classification arises from the epithelial component of ovary, but I won't be speaking details because usually the question doesn't come from here. What are the questions I have already put, so you'll get to know there. Okay, the main now they can ask you what is the lifetime of ovarian cancer. So, lifetime risk of ovarian cancer in UK is 1 in 50. Okay, it is 1 in 50, and this number is from strategy. Apart from this, sometime you will get question from this number also, that what is the number for inherited cancers. That means some genetic defects are there, and because of that ovarian cancer is there. So either it could be BRCA1 and BRCA2, or H and PCC group. So in this particular situation, lifetime risk of cancer, now you can see it is so much. Here it is general risk, lifetime risk is 1 in 50, but with BRCA1 it is 1 in 2, BRCA2 it is 1 in 5, and H and PCC it is 1 in 10. So much increased. But the question comes from this number. So 15 to 20% cases of ovarian cancer may have inherited genetic defects. Okay, usually we already know that it is epithelial cancers are not there in the women younger age. Usually they are in the postmenopausal women, and a peak incidence is 60 years. Okay, this line, last line is from the TOG. Okay, so ovarian cancer is sixth most common cancer in most common cancer in women, and it is fifth more cancer that causes cancer related death in the woman. Okay, so one time this kind of question also has come. So this is from the 2017 talk, this line. Okay, so it is sixth most common cancer and fifth most common cause of cancer related death, so that you should know. So Aarti wrote no audio, so is my voice there or not? My voice there? Hello guys, my voice there? Okay, fine. If any issue comes up, please keep on writing on the chat box. Otherwise, I would be speaking to myself. Thank you. Now, age relation with the cancer, a type of tumor, that is also important, because that when you have to solve question, this gives a clue. So germ cell tumor, we did in the last class. It is in the younger woman, less than 20 years of age. Borderline tumor usually occur when the woman is in 30 to 40 years of age, and invasive, what epithelial cancer more than 60 50, that is in the postmenopausal age group. So age group, with the age group also you will get some clue to solve your questions. Now this is from the NICE only. Now when we already know in UK there are levels of care are there. So primary care will be managed by GP in the community. So what will be the with what symptom patient usually present in primary care? And all this is important to know because the question are framed in the same way. Okay, so persistent abdominal distension, feeling full, early satiety or loss of appetite, pelvic or abdominal pain, increased urinary urgency or frequency, and considering various tests with the unexplained weight loss, frequency of change in the bowel habit, or fatigue. A test for ovarian cancer should be done for a woman who is 50 years or more, and if she is having irritable bowel symptoms in last 12 months, because if, this is usually a presentation of epithelial ovarian cancer. because irritable bowel syndrome presenting at this age is really rare. So these are the symptoms. If these symptoms, the patient comes to usually GP. So GP first, what the GP will do? So GP will do the physical examination. Okay. So this part is important because question, what will be the next step when comes in the question? Answer will be physical examination. So with these symptoms, there is a suggestion for ovarian cancer. Patient will go to GP, and GP then, GP will take the information, and then he will do the physical examination. And if on the physical examination there is a suggestion of ovarian cancer, so there will be direct referral. But if the GP sees and he doesn't think like that, then some test has to be done. Now you have to understand what are the tests done in the primary care. So in primary care, first they will do the CA125. Okay, and if the CA125 is high, so value is 35 international unit per ml. If it is more than 35, then second test what will be done is the ultrasound scan of abdomen and pelvis. So these tests are done by GP in primary care. Okay, now what the GP will do? So if ultrasound finding suggests of cancer, so she will be urgently referred. Okay, but second situation, if CA125 is less than 35, or if it is more but scan is normal, so in both of the situations, uh, probability of ovarian cancer is very less. So GP will do her reason to find what is the reason for her symptoms in investigation. That means it is not likely to be ovarian cancer. So if there is no cause apparent, then GP will advise her to come back. So every line here is important, because what next step has to be taken by GP, they will give you a scenario. For example, they will give that patient presented with all these symptoms, GP are in CA125, CA125 has come less than 35 and the scan is normal. What to be done? So answer will be assessment for other clinical causes for her symptoms. Okay, or so this way the question comes from this referral pathway. So therefore it is important. Okay, now patient is referred, so patient has come to secondary care. So what the test will be done in the secondary care. Now till now I was speaking primary care, what GP will do. Now patient has come to secondary care, what is done in the secondary care? So these are the tests done in the secondary care. So if CA125 has not been done, so it will be done, or ultrasound, if it is not done, then it will be done. Apart from this, if the woman is less than 40 years of age, then measurement of alpha fetoprotein and beta HCG and CA125. If the suspicion of epithelial cancer is there, then all these tests will be done. Here it is a little, here it is difference from the guideline who is there for the cyst in the premenopausal woman. There, if a complex cyst is there, okay, in that from that guideline, if the complex cyst is there in women less than 40 years of age, so they were doing beta HCG, alpha fetoprotein and LDH. Okay, so you have to find out the scenario. So if you find they give a complex cyst and then they put up a question, so answer will come from the guideline of cyst in the premenopausal woman. But if it is a cancer type like question, and they are asking what are the tests to be done in the secondary care, then the answer will come from NICE, and the answer will come, these are the tests to be done. These are the nice pictures from the NICE referral pathway. Okay, so these are the tests done in the secondary care. Now this is also very good flow chart. So again, the repetition of the same test done in secondary care. So now so CA125 and USG, if they are not done before, less than 40 beta HCG and alpha fetoprotein. Now after that, what will be done? They are calculating RMI 1 score. So, and if it is more than 250, then it will be referral to special onco MDT. Now onco MDT will decide the next care plan. Okay, now another few things you have to see here. If a patient you see and there is a suspicion of ovarian cancer, then consideration for CT scan of pelvis and abdomen and thorax, if it is clinically indicated, can be arranged to establish the extent of disease. Okay, this line is important. Why it is important? Because you will get question from this line. You will get they will give you some scenario, answer will be to perform CT scan of abdomen and pelvis. Okay, so these are the tests and the done in the secondary care. Now you already know what is risk of malignancy index I. So calculation is done, and how we calculate it, because the question comes from the calculation, and on the basis of this calculation you would be referring patient to secondary care. Okay, so U is ultrasound score, M is menopausal or status, and CA125 is the value in international unit per ml. So now this is this way the calculation is done. So U is ultrasound score. Now what the mistake usually people do here, I'll be just speaking about that. So now these are the when they give you a in your question, in ultrasound scan you have to find out these 5 things. These are the 5 things: multiloculated cyst, solid area, ascites, bilateral lesion, and metastasis. Okay, so if you find that only one criteria, USG criteria is there, then you will be one. You will be one. But if you find like 2 out of these 5, 2 are there, then you will be 3. Now, if you have got ultrasound 2 criteria, 3 criteria, 4 criteria, all 5 criteria, so ultrasound score in all of the situation, it will be 3 only. Okay, so for you there are 2 scores, one for ultrasound score 1, and if it is 2 or more than 2, then it will be U3 only. So here most of the people sometimes they make mistakes, so it is important to learn. Now if your patient is premenopausal, then it is 1, M is 1, but if she is postmenopausal, then it is 3. So now you can see the criterias are 1 and 3 and 1 and 3. Okay, and CA125 is the value that is no problem there. Okay, so I'm ultrasound 1 criteria will be U1, more than 2, 2 or more than 2 will be U3, premenopausal 1, postmenopausal 3, and this is the value for number. Okay, so this is the way of RMI or risk of malignancy index 1 calculation. Usually it is important because on this you will able to get questions. Okay, so this was the all about the referral pathway question that usually comes. Now how to manage them? So stage 1 is the early stage. Okay, so what is done in early stage? In early stage, usually they what the treatment they do is the like staging laparotomy, or it is surgical treatment. Now you will get question from this part also, therefore I have put it here. So what is staging laparotomy? That is done for early stage. So, and also you have to remember optimal surgical staging. So this is the criteria for it. So it will be, question comes from this part also. Okay, so what they do in optimal surgical staging, that you have to know. Okay, it is important for both part 2 and part 3 people, because in part 3 people, for part 3 people usually role player station also comes, and ovarian Viava station also comes. So what is the meaning of optimal surgical staging? So it will be midline laparotomy, thorough assessment of abdomen and pelvis. There will be total abdominal hysterectomy, bilateral salpingo-oophorectomy, and infracolic omentectomy. This part you have to remember because people make mistake here. Biopsies of any peritoneal deposits, random biopsies of pelvic and abdomen peritoneum, and retroperitoneal lymph node assessment. So the point to be taken care or understand here, that only for retroperitoneum they are doing assessment only, okay? They are not doing any lymphadenectomy here. So this part, people make mistake here. So this is very carefully to be understand that retroperitoneal lymph node only assessment is done, no lymphadenectomy. So as a part of surgical treatment. Okay, so this part is important to remember. So this is the optimal surgical staging that you should understand. That will help in answering your questions. Now, what is so for stage one, for stage 1 A and B, grade 1 and 2, usually no adjuvant chemotherapy is given. 1C and grade 3, 6 cycles of carboplatin they are giving. You will get question from this part also, so you have to understand. Now I just summarized stage 1 ovarian cancer treatment. So for stage 1, first optimal surgical staging or surgical laparotomy, like staging laparotomy. After that, histopathology will come to you. Histopathology will guide you that what to do next. If you get stage 1A, 1A, 1B or grade 1A, 1 and 2, then only patient has to be followed up. No chemo is given. But 1C or grade 3, 1C or grade 3, 6 cycles of only carboplatin is given. Only carboplatin. This part is also important to understand, because in rest of the advanced stages, they are giving paclitaxel and carboplatin, two things. Okay, this is the only one line you have to remember. Here, stage 1C and grade 3, only one chemo, that is a carboplatin, 6 cycles are given. So this is the summary for stage 1 treatment. Usually questions are formed this way only. Then coming to this is every chart is from NICE, okay? So this stage 2 to 4, they are saying advanced ovarian cancer. So what to be done in advanced cancer? They would be doing primary surgery, first line chemotherapy, then maintenance of chemotherapy, second line chemotherapy, and last will be the palliative care. Okay, so usually, so this way that they have given the pathway. So what type of surgery is done? What type of surgery is done? I'll be just this I will tell you from this, because NICE doesn't speak about that. So I have put it from BGCS ovarian cancer guideline. So this surgical update is important to understand and to answer questions. So what they want in surgical surgical staging, so it is very nicely given here. So in early cancer, they want complete macroscopic resection and adequate staging, what we have just discussed. Okay, now fertility sparing in early stages, consideration for fertility sparing surgery can be done, but it has to be MDT decision and discussed with the patient. Informed choice they can make. Another part important to learn, if you find a scenario like they gave you that incidental like surgery has been done for benign condition, and post-operative histopathology shows unexpected uh, the cancer condition. In that particular situation, restaging procedure has to be done by the gynecology oncologist. So maybe you may get question from this line. Okay, this part, and if fertility sparing surgery is not required, then they have to do optimal surgical staging. That this is the same optimal surgical staging that I have spoken. So this is from explanation for BGCS, but what I have already spoken that from NICE. Okay, and what they say that if the mucinous tumor is there, so appendicectomy should be performed. Okay, so this is the update from this guideline. Apart from this, in the advanced stage, if the patient is fit, then what is the aim of surgery? The surgery done is cytoreductive surgery. In cytoreductive surgery, whatever the visible part of the cancer is there, it is usually resected. Okay, it is usually resected. So this is the cytoreductive surgery. So in advanced stages, cytoreductive surgery followed by chemotherapy is given. This is a treatment usually given. But in if the patient is not fit for surgery, or some, or the cancer is too much advanced, then consideration for new adjuvant chemotherapy can be done. So new adjuvant chemotherapy usually 3 cycles of chemo are given. After that, interval debulking surgery is done. That will be followed by 3 uh, uh, remaining, cycles of chemo. So sometime, they will give a question and answer comes from here. Therefore, I have explained this. Now, this is from the strategy. So new adjuvant chemotherapy, first you have is the chemotherapy that is given before surgery. Okay, before surgery, if you are giving chemo, then that is a new adjuvant chemotherapy. So if the tumor burden is very high, consideration for new adjuvant chemotherapy is done. What are the agents used? Usually these are carboplatin and paclitaxel. Okay, so most common, what is the regimen? Most common regimen is 3 cycles of new adjuvant chemotherapy followed by a interval, then a debulking surgery is done. This will be first, after that followed by 3 cycles of chemotherapy. So this is from the strategy. So that will help you in understanding, because many times, people make mistake what is adjuvant and what is new adjuvant. So it is important to learn. So new adjuvant will be before we start any surgery. Adjuvant will be after histopathology has come. So you are giving treatment, that is adjuvant chemotherapy. So understanding of terms are also important. Now, this is a summary for stage 2 to 4 ovarian cancer treatment. So first, there are 2 lines of treatment. Okay. So first will be debulking surgery followed by adjuvant chemotherapy. Adjuvant chemotherapy is usually carboplatin and paclitaxel 6 cycles. Okay. But another situation, if the tumor burden is quite high, then there will be a new adjuvant chemo 3 cycles of carboplatin and paclitaxel. This will be followed by interval debulking surgery. That will be followed by rest 3 cycles of adjuvant chemotherapy. This is the sum up of the treatment according to stages, because your questions are based in that manner only. So it is important to understand. So this is again chart from the BGCS. So I just put it here, but this I have already spoken. So first, first there will be calculation of RMI index. If it is more than 250, referral, and if the suspicion of cancer, consideration of CT scan of abdomen and pelvis for staging. If clinical features are there, and CT chest may be done. If some symptoms are there, like then before going for surgery. So this is the again same thing, but it is a chart from the BGCS. Therefore I wanted to put it here. So till so that's complete pathway for the uh, this epithelial cancer treatment. Usually questions are framed in referral pathway and the treatment according to the stages. Therefore I have made in a similar manner. So till now, if anyone have any question, can ask me. Otherwise, I will be speaking about this SIP that explains genetic predisposition to gynae cancers. Any questions till now? Any questions till now? No question. Okay. So usually, the question comes from here also. It is important to learn. You will find, SIP is there. Uh, there is one old TOG is there, and but usually the question comes from here only, in this scientific impact paper. So I try to make the whole of the thing genetic cancer from this paper that explains it very well. and you will find question from there, and also it is important for both part 2 and 3 people. Now, 5% of all endometrial cancers, they are hereditary, and 20% of epithelial ovarian cancers are hereditary. These two number usually the questions come, so you have to remember this number. Apart from this, like there could be all this BRCA or like hereditary breast and ovarian syndrome, Lynch syndrome. Some rare syndromes are also there. These are no, all SIPs are not to be done, but this is important SIP. So COVIDian, PGA syndrome, leaf harmony. So these are also manifest with a gynecological malignancy. But these are very rare, and usually I have not seen questions. So details of these syndromes I never put. Now, question also comes from this. What is BRCA1 and what is BRCA2? Where they are located? So BRCA1 as a gene is present at the 17 chromosome, uh, like long arm at 21 position. Position is not no need to remember, but the 17q is important. BRCA2 is present at 13q, position 12.3. But again, it is not required these positions, but chromosome number you should know, because I have seen questions from there. So BRCA1 is 17q, and BRCA2 the mutation is at 13q. This minimum, this much would be enough. Apart from this, you will get question from here. So usually they will give you like BRCA1. Usually why we are worried, breast cancer can be there and ovarian cancer can be there. So what is the risk by 70 years of age for breast? If the BRCA1 is there, so breast cancer risk is 85%, and ovarian cancer risk is 63%, and BRCA2 breast cancer is 84%, and ovarian cancer is 27%. So this usually no, BRCA1 and 2, breast cancer number is easy to remember. It is 85 and 84, and the question usually doesn't come from here. Question come from this numbers. So this number it is real important. You have to remember this number. If you find older TOGS, and then this number will be different, but it will be parallel to this number only. So you have to remember this number, that BRCA1 it is 63 ovarian cancer, and BRCA2 ovarian cancer is 27. So this number you have to know, because this from this percentages question usually comes. So you can remember 63 by 27, whatever the way you want to wish. Now, what type of tumors are associated with BRCA? Usually they are high grade serous or endometrioid or endometrioid carcinomas. They are typically aggressive, and usually the patient present in the advanced stage. By contrast, mucinous carcinoma, they are less likely to be associated with BRCA. So sometimes you will find a question that with the BRCA, what type of cancer can be associated. So your answer will be high grade serous and endometrioid. Mostly it will be serous only. Okay, and these are typically aggressive, present in very advanced stage. This much knowledge is enough for answering your questions. Too much questions are not coming, but yes, they do come. Now there are two types of testing that you should know of. One is the genetic testing, and another one is the predictive testing. So diagnostic genetic test, it is a full screen of the gene, and that is done in any patient who has cancer. So if anyone has cancer, full set of full screen of gene is done. So this is a diagnostic genetic testing, because we are diagnosing what is the problem. Okay, a second type of test is predictive test. Like this is if any one member of family having one kind of cancer, and like so this test is done in the individual who has not a cancer. So with the family history, the targeted test is done only for one mutation. For example, one member have one disease, one cancer type is there, and we are testing same in another family member who don't have that cancer. So that will be predictive testing. That means you are with this test we are trying to predict whether this person has a probability to have cancer or not. So, I have seen question from this as well, and this usually asked by role player in the part 3 exam also. So this is important to learn. Apart from this, what the NICE guideline says. So if uh, patients, those have women without any personal history of cancer, but a high family history for BRCA1 and BRCA2 genetic testing, then if this risk is more than 10% for being a BRCA carrier 1 by 2, then usually the testing should be offered. Usually the testing should be offered. So maybe you will get number from question from this line. So if the risk of a person is for being a BRCA carrier is 10% and more, then usually the genetic testing is offered. So this may be important, because sometimes the question comes also, and you will get many questions from here. Okay, so now if a patient has BRCA1 or BRCA2 mutation, so what you will do? What you will do? So there are few things that has to. The patient is worried. Why worried? Because of for ovarian cancer and breast cancer. So for ovarian, what can be done for ovarian risk reduction surgery? That is the bilateral salpingo-oophorectomy is done. Okay, and for breast, either they will do risk reducing breast surgery or there will be breast screening. Okay, so these are the strategies that can be you know the management treatments for the women if they are having BRCA1 and BRCA2 mutations. So if the surgery is done, like if we have removed the ovaries for a woman having BRCA1 and BRCA2, so their risk of ovarian cancer will decrease. How much? This number is asked in the exam. So it is 80 to 96%. Now another question that will come in your head, that if we are removing both ovaries, how the remnant risk of cancer is there? So there is a remnant risk of 1 to 6% risk of primary peritoneal cancer still can be there, and that can happen up to 20 years after oophorectomy. Okay, so this part you have to remember, both part 2 people, because the question comes directly from this number, and part 3 people, that there is a station where the patient wants to remove her ovaries. So you have to tell this patient, in spite of we remove your ovaries, still 1 to 6% chances of having cancer is still there. It is not absolutely that all risk is removed. So this number is important for both of you guys. Okay, all people. Now there is a risk of, if the they are removing ovaries, so mortality risk is also reducing. So that is 60 to 76% reduction in overall mortality. So all three numbers that I have put here, all three numbers I have highlighted, question comes from every number. So you have to remember this number, this percentages important for both part 2 people and part 3 people. Now another, okay, so now you would be offering them what you like this uh, risk reductions, bilateral salpingo-oophorectomy, but at what age? For BRCA1, usually the chances of having ovarian cancer increases significantly after during her 40s. So the risk reduction surgery is offered at 35 to 40 years of age. Okay, so and for BRCA2, usually the ovarian cancer comes late, so surgery can be delayed till 45 years of age. So these both, so BRCA1 surgery is offered at 35 to 40, and BRCA2 it is 45. Question comes from here, you have to remember that. Apart from this, now if we are removing if we are removing the ovaries, so ovaries, if they are removed, then the hormones are going from the body. So also there will be decrease in the breast cancer also. So how much decrease in the breast cancer? In this is for BRCA1 it is 56% reduction in the breast cancer. On for BRCA2 it is 46% decrease in the breast cancer. But it is only be possible if the surgery is done before 40 years of age. So this number is also important. Now there's so many numbers here in BRCA thing, but I really can't help it because the question, these all numbers are important because usually question comes for part 2 also and part 3 also. Now ovaries are removed. So if the ovaries are removed, so there will be like menopause. So in BRCA1 and BRCA2 mutation people, if their personal history of breast cancer is not there, HRT can be offered to them till natural age of menopause 50 years. But if they have personal history of breast cancer, then HRT cannot be recommended because we already know breast cancer is absolute contraindication for HRT. So you may get question from this line also. Now, one thing is important to remember because you may get question from here, and BRCA associated serous carcinoma, usually it originates from the fallopian tube. And what is the lesion from where it originates? That is called as a STIC, serous tubal intraepithelial carcinoma. Okay, so this you have to remember because previously there was a TOG also, but you have to remember this much. And this is usually this lesion, these are they are present in the normal fallopian. These are distinguishable, what they say, from the normal fallopian tube, and they usually shed the malignant cells without invading the tube. So inside the tube, there is a STIC from where the cells are coming. And therefore, because of this, this could be explained that these days we already know that previously when we were doing hysterectomies and we were, leaving ovaries and tubes, but there had been change in the trend. If over the few years, if you guys are practicing, now if we do hysterectomy, we are removing tubes of every woman, only ovaries are left. This is because of because of this situation, because usually this cancer starts from the STIC in the fallopian tubes. Therefore tubes are removed these days in every hysterectomy. Okay, and and from this place only that primary peritoneal cancer is coming. Therefore we can explain to the role player, instead if we are removing ovaries, still they can have primary peritoneal cancer, because this is the answer. So you should understand that. Now though this BRCA people, they present with the cancer, they present at very late stage, and very aggressive serous cancer is there, but the prognosis is good because they selectively respond to uh, this poly ADP ribose polymerase inhibitor, PARP group of medications. This is sort of a chemo, and they very nicely respond to it. Therefore, in spite of having aggressive thing or serous tumor, their prognosis is good. That's all I had to say about BRCA1 and BRCA2 SIP. This much knowledge is enough for answering your question. Before I move ahead, any one of you have got any question can ask me. No question? Okay, so now this is the Lynch syndrome now this is the recent talk. So it is related to the topic. So I put it here. It is very complex talk, but I have put few things from where the question usually comes. No much details are not required. So you can get question from this numbers. Prevalence of Lynch syndrome in a patient with endometrial cancer, it is 3%. So if you see endometrial cancer and all the endometrial cancer, if they are, they are tested, so in 3% link syndrome will be the reason, and ovarian cancer 1 to 2%. Okay, so you may all the numbers are from TOG. So please repeat the last slide. This one you wanted?
Yes, please. Thank you.
Okay. Okay, so now coming to Lynch syndrome. So prevalence of Lynch in endometrial cancer is 3%. In ovarian, it is 1 to 2. Okay, so this number is important for part 2 people, because I don't think so for part 3 people the station can come from Lynch syndrome. Now, what is Lynch syndrome? Now, from all these parts, the question can come. Okay, Lynch syndrome is an autosomal dominant condition. So you have to remember this autosomal dominant condition for cancer predisposition. Usually, from where it arises, there is a dysfunction DNA mismatch pair system. So there is a problem in MMR, that is a functional DNA mismatch repair system. So problem is in the MMR system or mismatch repair system. So you can get question from here. Apart from this, like it is commonest inherited most common inherited cause of cancer. So you can get question from this also. So this is the most common inherited the most common inherited cause of cancer. Okay, if the inherited cancer they take in the picture, so Lynch syndrome will be the most common. I don't know whether this number is important or not, but it is 1 in 278. So 1 in 300 you can just say. Apart from this, what are the Lynch syndrome arises from mutations, and these mutations are called as pathogenic variants, and these are the few things. This is ML, this you have to, I think, remember part 2 people. MLH1, here it is L, then become S, MSH2, MSH6, and PMS2. Okay, so these are responsible pathogenic variants. So these are the variants minimum you have to remember, because one question I have already seen, I have put also, that is from the strategic SBA bank. So MLH1, MSH2, MSH6, and PMS2. Now it is a most common inherited cancer predisposition syndrome. What type of cancer can occur? So there could be colorectal, there could be endometrial and ovarian, and it has a most common high penetrance is there. Okay, so if the family history is there, so many people because of this penetrance will be affected. This will be important for you people. Now, what could be the risk of cancer in the Lynch syndrome? So any cancer, like overall cancer, if you think it will be 81%, this is from this picture only. Okay, these percentages are important for part 2 people. So any cancer will be 81%. Endometrium is 57%. You can see it from here also. Colon is 45% and ovarian is 17%. So if a patient has a Lynch syndrome, so probability of having any cancer will be 81%. If she's a female, endometrium cancer can come to her in 57% are the chances. Ovarian cancer can come at 17%, and the colon cancer can come in both sexes, and it can come in 45%. So this, I have put these numbers in the decreasing order. So you have to remember this part 2 people, this question can come from here, but these percentages are important. Okay, so endometrium 57, colon 45, and ovarian 17, okay. So this is real important numbers to remember. Now the question, so it is not a uniform disorder, though it is autosomal dominant because of this penetration degree of penetrance thing. So disease spectrum, it will vary, okay? It will vary. Apart from this, endometrial incidence of endometrial cancer in MH6 is high. MH6 it is high, okay? MH6 pathologic variant is as high as in MLH1 and MSH2. So basically you have to see this. Now this table will explain. So this is the, if you see endometrial cancer, so in endometrial cancer, so usually MLH1 is present in the most of the cases. MSH2 in also present in the cases, but MHS6 may be present in some cases, but PMS is the least common variant. PMS2 is the least common present in the endometrial cancer. So these are the few variants, pathological variant. This I have already discussed, and this is the cumulative incidence for endometrial cancer, but it changes with the age. So these are the incidences at 40 years. These are the incidences at 40 years of age, and these are at the 60 years of age. Now if you see it from at the 70 years picture, so you will find MHS2 is 56% present in 56%. So it has a very high probability. This variant has a very high probability of having endometrial cancer at the 70 years of age. And like and PMS2, it has got the least probability. It is only 26%. So it is ovarian like endometrial cancer is less in this PMS2 type of pathological variant. So why I'm speaking about that, because this is the question from strategy question bank. So this in this question, what they say is 40 years old woman have a genetic testing done for Lynch syndrome because her sister has colorectal cancer. Now she has a mutation of MMR gene that giving her lower chances of endometrial cancer. So what could be the type of gene? So what should be the answer? What should be the answer? B. How it can be B?
E.
Lowest chances of cancer. Lowest.
E.
Very good. Lowest chances. Now you can see PMS2 has got a lowest chances of cancer. Okay, this one. No, a PMS2. It is PMS2. If you see this table at 70 years of age, so answer is at 70 years of age, less percentage of people have PMS2. So answer will be PMS2. So this is a question from strategy bank. Therefore, because of that, I have put that incidence table. So answer is PMS2. So this gene is likely to have less chances of or lower chances of having endometrial cancer. So this is the answer. This you should remember. Maybe you get in your exam same question. Now, if the patient has a Lynch syndrome, so some risk reduction strategies are done. What is done? It is the hysterectomy, bilateral self-ingophorectomy. This is one thing is done. Apart from, so various ages they have given, but I don't think so. These ages you can remember and you should remember. It is not that required. Apart from this, if the BMI is high, so what from 18 years they want aspirin. So these are the two things that you have to remember. These are the risk reduction strategies that can be offered to the patients of Lynch syndrome. So now this is again same thing. So hysterectomy and bilateral self-ingophorectomy should be offered at 40 years of age in the Lynch syndrome. After that, if there is a risk of menopause, so estrogen replacement therapy, usually transdermal application can be done. Now, a few things what the talk says, that OCP usually reduces sporadic and risk of endometrial and ovarian cancer, and also it is reduces in ovarian cancer in the BRCA mutation also. LNG-IUS usually reduces risk of endometrial cancer in the general population, but these two strategies, there is no conclusive data that these two intervention will be of any help in the woman of Lynch syndrome. You may get question from this part also. So the conclusive data for these interventions in the woman with the Lynch syndrome is not there. Now, few things, this is a sum up.
Sorry,
So,
can you
Ma'am,
repeat last
ma'am, can you explain it once again?
contract?
This hysterectomy. Yeah, this slide, ma'am.
Okay. Please, you mute yourself. Okay, so risk Lynch syndrome is there. Very high chances of endometrial cancer. So what we have to do some risk reduction strategies. So what is a risk reduction that can be done? So it could be hysterectomy and bilateral self-oophorectomy, and usually it is offered at 40 years of age. Number one. So if hysterectomy and bilateral self-oophorectomy is done, so what will happen? There will be menopause. So what can be given for the menopause? So it will be estrogen. Usually preferred is a transdermal application for protection of all menopausal symptom. This estrogen, if the offered, it has protection against colorectal cancer also, and it doesn't increase the breast risk. Okay, this now this part is finished. Come to second part. Usually, if we offer OCP to any woman, then it generally decreases the chance of sporadic, that is the general risk of endometrial and ovarian cancer. And if any patient is having BRCA1 and BRCA2 mutation, OCP is given to them, then also they will somehow decrease the chances of ovarian cancer. Okay. Second, if any woman, if we give LNG IUS, it causes endometrial thinning. So it will decrease the chances of endometrial cancer, okay, in general population. So these two are the risk reduction strategies for endometrial and ovarian cancer. But these two strategies, they will not help if to reduce breast cancer, endometrial cancer and ovarian cancer if the patient has Lynch syndrome. Is it clear now?
Yes, thank you. Thank you. Clear.
Thank you, ma'am. It's absolutely clear.
Okay. Now this part is important because you guys may get question from here. So what is the screening and diagnosis? So what NICE recommends that all women of endometrial cancer should be screened for Lynch syndrome. You may get question from this line. What type of testing is done? These are tumor-based testing. That means once the hysterectomy is done with the specimen, these testing are done. So these are three kind of testing. This is immunohistochemistry. Immunohistochemistry, usually what this immunohistochemistry it identifies MMR deficiency. It is that there is a lack of a specificity associated with loss of MMR expression. This much, it is difficult to understand. Only if you could remember these three lines, it will be of helpful, because we have got a very less idea about this pathology things. So you just remember these are the tumor based testing. Immunohistochemistry to detect MMR deficiency. This much knowledge is enough. Apart from this, another thing that is checked, that is microsatellite instability analysis. So these satellites are repeated DNA motifs. Okay, and there is an instability that is seen in Lynch syndrome. Only this much is enough. So there is a microsatellite instability is there in Lynch syndrome. Apart from this, germline testing can be done. So it could be germline testing is done in the patient. If the diagnosis of Lynch syndrome is made, then germline testing is done. So these germline testing is done using next generation sequencing NGS. Maybe you will get question from here. It is expensive and can be done in the specialist center. So if the confirmation of Lynch syndrome is done, then germline testing should be offered to the person. and it is very expensive, and it is done by next generation sequencing technique. This much knowledge is enough. Too much knowledge about this pathology even I don't have. Okay, this will help you in answering your question. More than that, I don't think so they will ask you any question. Now this part I have already spoken. So risk reduction strategies: hysterectomy. Okay, hysterectomy. Now hormonal therapy, this I have already spoken before. Aspirin, this also I have already spoken. And lifestyle modification. This will be smoking cessation and maintaining a healthy body mass index. All these things will be there. And gynecology surveillance, usually what they say, there is no strong evidence to support gynecological surveillance for early detection of gynecological cancer in Lynch syndrome. So for gynecological surveillance, there is no evidences there. So this much knowledge is enough for the Lynch syndrome. Anyone of you have got any question can ask me, though I have got less idea about it. Any question? Okay, so this is another talk, I try to put all ovarian thing, and this is recent talk, so this is important also. So this is the management of ovarian cyst in children and adolescent. Very good talk, it helps in the our clinical practice also. So it is really important. Now, a few things from where you can get questions you have to. So ovarian cysts are most common cause of abdominal cyst in the female fetus and neonate. So if the scan is done for a mother in third trimester, okay, usually some abdominal cyst if can be seen. So this would be ovarian cyst. So that you should know that ovarian cysts are the most common cause of abdominal cyst in the female neonate or female fetuses. If she is fetus, then it will be seen in the third trimester scan when we do it. Because apart from these are unilateral and simple. There has to be simple. And why it happens? It is because of fetal gonadotropin, maternal estrogen, or placental human, that is HCG. Okay, this is the reason. So usually these complication will be torsion, rupture, hemorrhage, or compression of nearby structure if they are very big. If they're very big, there will be like how much space in the abdomen of a baby or fetus is there. So if it becomes big, so compression of nearby structures will be there. Usually, we are not doing anything. Management is conservative. Only just we need to follow with the serial scan. But if they are very large, if torsion is there, then if any emergency, then consideration for surgical management. Yes, it has to be done by pediatric surgeons. So you may get some question, SBA from this part. So I put it here. Now, what are the types that could be there? So usually it is simple cyst that is present in 60% of the cases. This number is important because you can get some question from this number 60%. And if the scan shows complex cyst, so what could be the most common? We know this very well. So it could be mature cystic teratoma or dermoid, mature cystic teratoma or dermoid. Another set of situation, if the malignancy is there in like child or adolescent. So what is the most common tumor? So this question I have done in last class also. This was from this talk. So answer would be like granulosa cell, juvenile granulosa cell tumor. This is the most common. All this yellow, though these are the table. This is the table from the talk. What type of cyst, ovarian cyst and neoplasm can occur in child or adolescent? But the at least minimum this you have to remember. So simple cyst 60%, complex cyst if it is there has to be mature cystic teratoma or dermoid. If it is malignant, Malignancy occur in 4 to 16%. Okay, 4 to 16%. And juvenile granulosa cell tumor will be the most common. So answer question will come from here. Now coming to benign ovarian cyst. So in the in adolescent, yeah, they has to be simple. Usually they are called in the child, there is an intermittent gonadotropic production by the pituitary. Though we already know that HPO axis remains silent, but there could be intermittent gonadotropin production. So because of that, this happens, but most of the time they will go back by themselves. Another differential diagnosis that has to be remembered, even we see this in our clinical scenario also. So paratubal cysts are very common in young people. Usually they grow very large whenever the if like I have seen many patients in the clinical scenario also. Usually when the patient comes to you, it is already 9 to 10 centimeter big cyst, and they usually people confuse them from ovarian functional cyst, but these are paratubal cyst. Usually these cysts, they will not go by themselves. There is no conservative management for paratubal cyst, and if the cyst is large, then it has to be done managed surgically, laparoscopically only. And it is very simple laparoscopy for them. You just make a small puncture in the and just suck it out, and only with a cauterizing their they have got a very small pedicle. Okay, you'll be able to coagulate it. So it is done very nicely. And how clinically in laparoscopically you will be able to identify whether you are dealing with a simple cyst or paratubal cyst. On the paratubal cyst, if you can even at a look you can see it, because vascular pattern over their capsule is different from the simple cyst. Okay, so this is just in clinical experience. So paratubal cyst surgery has to be done. Now, if the patient is coming with a mid-cycle pain, we already know why she's coming. Mid-cycle pain is considered to be the possibility of hemorrhagic cyst or functional hemorrhagic cyst. Sometimes patient do get admitted because they have free fluid or hemoperitoneum, but usually no treatment is required. On conservative management, patient becomes okay. So these are all about that you should know about the benign ovarian cyst in child or in the adolescent. It helps in your question and also your clinical practice. Now, if a child or adolescent comes with a complex ovarian cyst, so what you will think of, okay, some issue has there could be possibility if the complex cyst is there, and if it is not mid-cycle or hemorrhagic cyst, another possibility is dermoid or mature cystic teratoma. They are present in 55 to 70%. You can get question from this number because it is a recent talk. Usually it occurs in the ages 6 to 15. 10% they could be bilateral. Okay, because sometime whenever if you are doing ultrasound and if you see a dermoid in one ovary, you always go and check second ovary, because sometime both ovary contains dermoid. So 10% it could be bilateral, and I have seen it myself. Apart from this, 15% will come with torsion. Why torsion is so much common here? Because we already know this dermoid has a fat content, and fat is light. So because of their lightweight, they are very easily they can go for torsion. Okay, therefore 15% dermoid cyst present with abdominal pain and torsion. Spontaneous rupture can be there, less than 1% of the cases. Okay, apart from this, malignant transformation, if it occurs, it can occur in 1% or 1.7%. But so many numbers of percentages, but question can come from all of them. Okay, apart from this, some rare complication of dermoids, because we already know these are mature teratoma. They have got various type of epithelial like cell lines are there. So sometime they can rare medical complication could be there. So like they can this includes a carcinoid tumor. So in carcinoid tumor, usually a lot of that like serotonin and all these neurotransmitter they secrete. So all these symptoms of flushing and all these things will come. Then struma ovariae, usually it's secreted too much of thyroid hormone. Then they can present with a hemolytic anemia, and also they can present as a anti and NMDA receptor encephalitis. These three, you should remember, because sometimes they can ask you from the question in the SBAs, it can be asked. So to sum up numbers, so in the adolescent, 55 to 70% are dermoid cyst present within 5 to 6 to 15 years, 10% bilateral, 15% will have torsion, 1% spontaneous rupture, 1 to 7% malignancy. So this all information is real important, can be asked as a SBA in your exam. Apart from this, you may get this as a question, like if the dysgenetic gonad is there, so sometimes gonadoblastoma and dysgerminoma both can be there. So sometimes the patient, when they come with a dysgenetic gonad, so possibility of these two tumors are there, gonadoblastoma and dysgerminoma. Therefore, if you might have read that androgen sensitivity syndrome, usually we offer them a gonadectomy. Why? Because we are worried about this, that gonadoblastoma or dysgerminoma can come, so we remove their ovary gonads. It happens in dysgenetic gonad. This is just an example. So what could be the malignant ovarian, now young adolescent people and with malignancy? So what first thought comes, it could be what we read from our table. The most common is juvenile granulosa cell tumors. So these are the most common, okay, and usually young, so 16 to 6 to 13 years they will come, and most of the time they are present unilateral, present limited to one ovary. So surgical they will only can be managed with a surgical resection, okay. And most common presenting feature, so this you must be knowing and you have to know, because they secrete hormone. So what can the patient can present with a pseudo precocious puberty, hyperpigmentation of breast areola, breast enlargement, vaginal discharge, pubic hair growth. Usually these are estrogen secreting, but sometimes they could be the presence of excessive androgen is also there. So if excessive androgen is there, then there could be clitoral enlargement, there could be hirsutism, there could be deep voice or irregular periods or amenorrhea. So this could be this could be the most common presenting symptom. So that this part, everything appears to be very important and the question can come. So this, you have this much you have to know. Apart from this, usually surgery is done, and after surgery chemotherapy may be required, and if the chemotherapy is done, then 3% chance of premature ovarian failure can be there. This will same number will come in another talk also. So if the multi-agent chemotherapy is done to young people, 3% chance of POF is done, is usually there. Now these are the few syndromes sometime may get question, that ovarian neoplasm is there. There could be possibility of some inherited syndromes. These are the syndromes: Ollier, Maffucci, PJ syndrome, Fraser syndrome, Dicer syndrome. Just see their names if anytime they are asked in the exam. Otherwise, no need to remember too much about them. So this much knowledge about juvenile granulosa cell tumor will be enough. So sometimes they can ask what could be the presenting symptom. So most common presenting symptom will be pain, and it will be present in 30% of the patients, okay. Another symptoms, it could be abdominal distension and mass, weight loss, polymenorrhea, menorrhagia, precocious puberty, dysuria, constipation, leg pain, limp. These are the unusual symptoms. and yeah, fever, nausea, vomiting, backache, something. If these are the usually, if any acute emergency or torsion is there, maybe you can be asked question that the most common symptom of presentation will be pain, that is in 30%. Okay, this part is real important because you have to remember when if a patient usually comes to you in your clinics, so tubo-ovarian or torsion in child, so it like when the patient usually comes with a acute and unilateral pain. Okay, so unilateral pain, and usually it is acute, unilateral and intermittent pain, and patient will present with nausea, vomiting and tachycardia. This is the usual presentation. These symptoms will help you in answering many of your questions. Okay, this apart from what is the incidence of torsion, it is usually 7 to 10, but in very old previous talk it was 11% written, so it is near to this number only. So this you can get question from here: incidence of torsion, ovarian torsion in young child, in children, it is 7 to 10%. Apart from this, like usually this patient when they can, and it is unlike appendicitis. In appendicitis usually migration of pain is there, but this pain doesn't migrate, it is like constant at the same unilateral place only. And you can get question from here. So what is where it is common, right or left? It is right side, it is common, and ratio of right to left is 3 to 2. And what is the reason? This is the reason. Usually on the left side sigmoid colon is there and that is fixed, so there is a limitation of movement. But on the right side mobile cecum is there, so movement play there is a space for the movement, and a little longer mesosalpinx on right side. Okay, this is also the reason. So little longer mesosalpinx and ovarian ligament on the right side. Because of these two condition, tubo-ovarian torsions in child, it is more common right side as compared to left side. So this much also you need to know. Now if the young patient has come to you and you have to make the diagnosis, so first of all USG scan is done. Then if you find complex cyst, and on the complex cyst you're not able to find okay what could be it, and you want more defined picture, you will arrange MRI scan. Okay, MRI scan. But if you have got suspicion of any bowel involvement, or malignancy, then consideration for CT is done. Apart from this, like on the scan, if there is unilateral ovarian enlargement, that means only one side of ovary we find very big and edema is there. So big ovary with edema, so there is a this would be the suggestion of ovarian torsion. Okay, and also if you guys have done ultrasound, usually when we see ovary, so follicles are present all over, but here in this particular condition follicles are pushed to periphery, so arrangement of follicles in periphery will be there in USG scan. And if it is like very delayed condition, then there would be Doppler signals, maybe Doppler signals that time may be absent. And in the initial stages, if you see Doppler signal, so because of the torsion, the pattern that is called is a whirlpool pattern. It is not given in this talk, but it is the before Doppler signal goes, and if you do color Doppler in the early stages, so vascularity shows whirlpool sign. Okay, so it is a whirlpool sign. So these are the way of investigation. Apart from this also you have to remember as this B rule and M rule. This is from the 62 number guideline. Just for the revision I have put it here. You get direct question from here also. So what is the so if the B rule is there, If the then this point towards the benign lesion, and M it point towards the malignant thing. So what is the B? I'll just read it. That will be revision for your guideline number 62. So what are the B rules? One cyst, that is the unilocular cyst, and if any solid area is seen, its diameter will be less than 7 mm. So it will be, now you just see how it will be very small, okay. And acoustics shadowing, usually if you do like if you're a person who do ultrasound, you will find at the posterior wall, because the fluid is there, so because of that there could be enhancement on the posterior wall. So usually posterior shadowing is there. If you might have seen, if you are doing ultrasound, and like if it is multilocular, so then the size has to be less than 10 centimeter. There will be no blood flow on Doppler. So these are the B rules. And what are M rule? It is very clear. So there will be irregular solid mass. There could be ascites, papilla more than 4, papilla at least 4. Okay. And diameter will be, if it is irregular solid, diameter will be more than 10. So more than 10 centimeter irregular solid. Apart from this, it has to be high vascularity. So there would be very high vascularity. Apart from this, like what are the like in imaging was done for the diagnosis. So few other tests are done, that will be full blood count, CRP, and tumor markers. So these tumor markers, I have already discussed in the last class also, that you already know. So whatever the suspicion is there, according to this tumor marker is done. So alpha fetoprotein will be raised in immature teratoma, Sartorius egg cell tumor, York sac tumor, and embryonal carcinoma, alpha fetoprotein. Okay. HCG, we already know it will be in dysgerminoma and embryonal carcinoma. LDH is 2 in dysgerminoma and immature teratoma. CA125 in epithelial, chorioembryonic antigen in the epithelial, estradiol GCT, testosterone Sartori cell tumor. This table I have spoken in the last class also. Now here lies the most important, how to manage now. How to manage now, like I try to simplify this so that it becomes easy, because there are so many flow charts, how to remember so much. So if a patient is coming and like with a pain in abdomen, menstrual problem, or a precaution, anything, then first of all you are doing transabdominal scan. We will these are the young children, not sexually active, so there is no TVS. Usually we will be doing transabdominal scan. On the transabdominal scan, if we see the cyst is less than 5 simple cyst, okay, simple cyst less than 5 centimeter, then we'll do nothing. We'll ask them to come after 3 months. Okay, so we'll ask them to come after 3 months. But if it is 5 to 7 centimeter and no symptoms are there, so again we'll scan them after 3 months time. Okay, so we scan them after 3 months time. So same is written here. If simple cyst less than 5 centimeter or 5 to 7 having no symptom, we'll call them after 3 month time and we'll do scan again. Now second situation, cyst is 5 to 7, but patient has symptom. If the symptoms are there, so that will raise suspicion, something is wrong. So we'll investigate more. What we'll do tumor marker or MRI for the clear definition of the cyst, and accordingly then the treatment will be planned. And if it is 7 centimeter, if the simple cyst is more than 7 centimeter, yes, in that particular situation, uh, we can give her 2 options depending on the situation. Either it could be surgery, or either it could be rescan after 3. If there is, like if the patient has 7 centimeter cyst and she has got no symptom, and so you will give her 2 options. Either she can go for surgery, laparoscopic ovarian cystectomy, or rescan can be done, because this patient is asymptomatic and she's a young child. So same thing I have put it here. Okay, so this is the summary. Now coming to the complex cyst. if a complex cyst is there, so in that particular situation, if it is like if the complex cyst is there, then we have to do tumor marker, alpha fetoprotein, HCG, LDH, and CA125, and MRI if it is required. Now, if there is no, if the cancer suspicion is there, then refer to onco-MDT. If there is no suspicion of cancer and it is more than 5 centimeter, or the patient has symptom, then surgery. So and anyhow, anytime if we have got cancer suspicion, always answer will be referred to onco-MDT only. Onco-MDT only. In all of this condition, patient should be referred to PAG, pediatric and adolescent gynecology clinic, PAG clinic also. And if the patient is coming in the emergency condition, acute abdomen, then usually imaging to perform surgery should be done within 4 hours of the presentation. So it should be done as early as possible. Okay. So now the take home, what you can remember, if the simple cyst till 7 centimeter, if she's asymptomatic, you will call for rescan. If symptomatic, then you will go for surgery. So 7 is a cutoff for simple cyst. Similar thing if you go for complex cyst, do your tumor marker. And if she is more than 5 centimeter, and if they have symptoms, you have to go for surgery. Cancer suspicion, always onco MDT. So this is like the sum up to manage if the adolescent is coming with the cyst, simple cyst, complex cyst, or cancer. So any question till now? Any question? Okay, now this is just a question I made. What is the risk of chemical? Yes,
B, ma'am, point 2.
yes, it is B. Everybody knows it. What is the recurrence of recurrence after dermoid surgery? Any anything you can tell.
I'm 10.6.
Very good.
Point 5.
10.6. 10.6. Very good. Who said 10.6? Read very well.
Nivedita, ma'am.
Okay, good. So, what is the treatment for ovarian torsion? So many times you will find a question, and so if the adnexal torsion is there, so we have to do surgery as early as possible to avoid any long-term damage or oophorectomy. So, what is the current recommendation? The current recommendation is to do detorsion with or without cystectomy, even if the ovary look necrotic. So there is an old TOG also there in 2012, but this is a new one, 2020 TOG, and this says the same. This you will find answer of many question, because what the way multiple studies have shown, even after detorsion, ovarian function, and the ovaries blue black. You see ovaries blue black. Even after detorsion, ovarian function comes back. So they're not removing ovary. Okay. Apart from this, if they usually after detorsion, gonadopexy is done, especially if previous oophorectomy history is there. What is this? Usually what they will do, they will put some stitches on the ovary, or it will be to the to somewhere in abdominal wall, or to somewhere on the round ligament, so that they will fix it. That is pexy, so that it will not rotate again. It will not go for torsion again, but completely it will not be able to present. It is still mobile hanging or organ. Okay, so this could be done. So basically you have to know this yellow line. Your answer will be done from here only. So that's all about, that's all. I like try to make very detailed presentation for these two talks, because these are the recent ones and important is good topics for clinical practice on the questions also. So any question about that childhood, like adolescent talk, sorry, childhood adnexal masses talk? Any question? Okay, no question. Okay, this talk is also very important, very good talk. Basically, it helps in the clinical practice also, apart from this exam. So, like adnexal masses in pregnancy. So, what is the incidence? Incidence is this much. Maybe you will get some question. So, you should know it is 0.19 to 88%. And incidence of ovarian malignancy in pregnancies 1 in 1500 to 1 in 32,000, because this type of question comes from how much incidence of like appendicitis is there. So I put this number for the visual impression. Now there could be some functional cyst, and the pregnancy, it creates a chaos because identification becomes difficult. So what is the corpus luteal cyst? Corpus, we already know that. What is corpus luteal cyst? But what important to remember that it usually regresses by 8th week of pregnancy. Okay, so usually what I used to know is 12th week, but there is a question I have seen and the answer was 8th week. So you have to remember this. Only for this I have put this, that corpus luteum usually regresses by 8th week of pregnancy. Apart from this, you should see high vascularity, so the ring of fire will be there. Okay, so this is a ring of fire. Apart from this, follicular cyst, we already know follicular cyst, usually they are less than 6 centimeter, and if on the scan, if you are doing scan for the first pregnancy patient, you find a cyst, so usually we'll do nothing, we'll wait it, because before 16 weeks it will resolve by itself. So just remember this two: corpus luteal cyst go away by 8 weeks of pregnancy, follicular cyst uh, usually less than 6 centimeter, they will go away by 16 weeks of pregnancy. So from both of these numbers I have seen questions. Now hemorrhagic cyst, it can be there. Usually it is managed with a conservative management, simple analgesia only, but sometimes it is very difficult because they look like as a malignant lesion. So these are the adnexal masses in pregnancy. No need to remember, and no question is coming from here. What you have to know is the unique masses to the pregnancy. This much you need to know. So these are the unique to pregnancy. Okay. Hyperstimulated ovaries, we already know if the patient has OHSS, or if it is a hyperstimulated cycle, OHS can be there. So that will show hyperstimulated ovaries. Okay, rest 3 I'm speaking. Now, what is hyperreactio lutinalis? Hyperreactio lutinalis, it is, sonographic appearance will be similar as hyperstimulated ovaries. Usually, why it happens? Because of excessive response of circulating beta HCG, and there is no ovulation. So in the pregnancy, there is no ovulation. We already know that, but beta HCG is very high, and this ovary, it is getting stimulated. So that is hyperreactio lutinalis, and so this is a reason, hyperreaction to beta HCG. Second, important to remember, maternal virilization occurs. Okay, maternal virilization occurs in 14 to 25% of the cases. So these two lines are important from the hyperreactio lutinalis. Second important thing, luteoma of pregnancy. It is here usually stromal cells are replaced by luteinized cells, and they produce a lot of androgen. So maternal virilization occurs, that occur in 25 to 30% of the cases. Apart from this, if the female baby is there, 50% chance that baby will get virilization. So this is a lutoma of pregnancy that also have to be remembered. So you have to remember this hyperreactio luteinalis. Also, you have to remember lutoma of pregnancy. You will get question from there. Apart from this, heterotopic pregnancy occur in 1 to 2%. Usually we know it is happening because of ART only. So this part you have to remember, 1 to 2% is risk of heterotopic pregnancy. Now again, what is the most now the simple cysts are done. Come to complex cyst. So what could be the complex cyst in pregnancy? Again, it is the same. Most common is mature cystic teratoma or dermoid cyst. Same we saw in the adolescent also. So usually it is most common adnexal cystic mass in the pregnancy, but we after 16 weeks, because before 16 weeks it was follicular cyst. After 16 weeks, if you are able to see possibility of dermoid, it is usually less than 6 centimeter, and the cause is no problem. But if they becomes more than 6 centimeter, then they can rotate, because fat, they are light, they can rotate. In 27% of the pregnancy patient, they can rotate. Okay, so all these numbers you have to remember. So it is most common after 16 weeks. More than 6 centimeter is a very high probability to go for torsion, and risk of torsion in 27%. Okay, so it could be, USG can be done. So usually that okay, because of the fat ball can be seen, or this fat content can be seen in the MRI also. Okay, this is the typical of mature dermoid or malignant or mature cystic teratoma. So after complex cyst, again there will be malignancy. After that, again there will be like malignancy. And if the malignancy is there, so what could be the malignancy? So dysgerminoma is the most common malignancy that can happen in pregnancy in ovary, and it do have a good prognosis. So it do have a very good prognosis. They are sensitive to chemotherapy, radiotherapy, and the treatment plan will be discussed in MDT. Apart from this, borderline tumors. Borderline tumor are the tumor, they are having low malignant potential. And how we can differentiate this malignant borderline tumor from invasive lesions? Because here stromal invasion is not present. Ovarian stromal invasion is not there. Okay, they are mucinous or serous, and they have a crescent sign. The question I have seen already from this crescent sign, so I put this picture also. So crescent sign is seen in USG imaging. That shows a rim of normal ovarian tissue. You can see in the picture in between the calipers that they have shown the, this is a cyst, and here lower part of it there is a crescent tissue, and this is the normal ovarian tissue. This is the normal ovarian tissue. So this is a crescent sign. So this sign is helpful in diagnosing, in excluding invasive ovarian cancer. Okay, if the crescent sign you find in your scan, then you can be sure that you are dealing with the you are dealing with the non-invasive ovarian lesion. Because if the on the other side, if the invasive lesion is there, so there could not be that much clear boundary. You will find haphazard, irregular solid mass. You will find haphazard irregular solid mass, so it will not be there. So crescent sign is the representative of, represents the rim of normal ovarian tissue, and it excludes invasive ovarian cancer. Question has already come from this line. Now again, what other ovarian mass can be there? It could be tubo-ovarian abscess. Tubo-ovarian abscess. So what could be the feature? There could be patient will present with a fever, and it will be swinging pyrexia, okay, coming and going, and abdominal pain. So treatment of PID is given, but doxycycline is contraindicated beyond 15th week of the pregnancy. Why? Because it causes uh, tooth and bone discoloration and inhibit bone growth. Okay, so this part you have to know, because again the question has come from this doxycycline part. So again I put it here. Now, what could be the diagnosis? Diagnosis will be first line, what you will do. It will be the ultrasound scan only. But apart from ultrasound scan, consideration for Doppler can be done. But this Doppler will be not too much, value is not there in pregnancy. Why? Because in pregnancy, the already the vascularity is so much because of the new angiogenesis. So it has got less importance. Consideration for MRI or CT scan can be done. Basically it is USG scan. If differentiation of more more defined picture of that mass is required, then MRI to be done. But if any suspicion of malignancy, consideration for CT scan is done, because we already know, because CT scan causes the radiation exposure also. These are the few things that were present in the talk. That this much you have to remember, because that will help in finding your question. I'm not reading this. So with the corpus luteum in USG scan, you will find ring of fire. I just showed you ring of fire also. In hyperstimulated ovaries, there will be spoke wheel appearance, like a wheel. Okay, it will present like a wheel. Dermoid, it will be white ball. Endometrioma, ground glass appearance. Hydrosalpinx looks like beads on a string. Beads on a string. These are the buzzwords in in the USG scan. Sometimes they will give only this words only, so you will be able to make diagnosis. And in Thousand, there will be edema and loss of Doppler signals. Okay, so these are the USG signs and these are the pathologies. Now tumor marker can be can be seen in pregnancy, but the problem is there, because interpretation of the results will be very difficult, because CA125, it is produced by the decidua also, so they have higher cutoff 112. Okay, 112 in between 11 to 14 weeks of pregnancy. So you may get question from here. So like CA125 high cutoff because it is produced by decidua. LDH, no change in the pregnancy, so it can be used as a tumor marker. Apart from this, HCG and alpha fetoprotein, they change in pregnancy, we already know. So out of this tumor marker, only LDH is not changed in the pregnancy, so we can use it. Now, how would you manage in the pregnancy? So most of the time, if they are presenting less than 16 weeks, they will be, it is a conservative management. It is a conservative management. But so the follow-up ultrasound is done at 16 to 14 to 16 weeks of gestation, because till that time they will think that it will go by itself. Apart from this, if any intervention you want to do in pregnancy, so it has to be delayed till 14 to 16 weeks after, because we know whatever the surgery is done, it is done in the second trimester. So there will be follow-up, they will wait for conservative management by 16 weeks. There will be follow-up scan by 14 to 16 weeks of gestation, and if any intervention is required, that will be done after it. Usually, no, this is the in the pregnancy, if the cyst is very big and it is causing acute pain and like it is obstructing labor, then consideration for cyst aspiration can be done in pregnancy. Okay, it is also written in the talk. But if they are only aspirating the cyst, chances of recurrence will be very high. It is 33 to 40%. This is again what before we read is the Adnexal 1000 in the adolescent. Now it is adnexal torsion in pregnancy. Okay, so it is important. So what is the incidence? 1 to 5 in 10,000 pregnancy. Maybe you can get question from this line. Where it happens more commonly, it occurs in the OHSS, hyperstimulated ovary. Even in the guideline also you will find OHSS guideline, they have spoken about torsion. So it can occur in 16% of torsion pregnant women. Usually it will occur in first and second trimester. Okay, patient will present with a pain that would be intermittent, usually one-sided, nausea and vomiting and tachycardia. Okay, apart from this, diagnosis will be what are the tests can be done. So it will be WBC. WBC will be mildly elevated. Apart from this, another will be CRP, but CRP will be the non-specific marker. See, because it may rise in other conditions also. Usually it starts to rise 6 to 8 hours after onset of torsion, and peak of CRP will be in 24 to 72 hours. Maybe you may get question from this part. So when the CRP will peak, it will peak at in the torsion 24 to 72 hours. Diagnosis is done by the USG. I have already spoken. Ovary will be large erythemas. There would be, loss of signals, Doppler signals, or what they are saying is avascular center. That means no vascularity. What could be the treatment? Answer is this. In the pregnancy, laparoscopy with adnexal detorsion, either aspiration of cyst, ovarian cystectomy, or salpingophorectomy. In the pregnancy, they are doing these three things: adnexal detorsion, aspiration of cyst, or ovarian cystectomy, or consideration for salpingophorectomy. So maybe in some cases, if the necrosis is there, because it is pregnancy, and in the pregnancy, usually we already know that one time surgery has been done. There will be no role for going for surgery again. Interval surgery cannot be done in pregnancy because it will be so difficult. So consideration in some cases for unilateral salpingophorectomy they are doing. Okay, so this much. So many questions of the torsion comes, and this talk really answers all the questions. What could be the indication of surgery in pregnancy? Acute abdomen, mass suspicion of malignancy, rapidly growing mass, increase in size in 2 scans, more than 20%. You may get question from this line. Okay, and any cyst more than 10 centimeter, that will cause obstruction. So that will also indication for surgery. You may get question from all of this part. So these are the indication of surgery in pregnancy. So again, this is a management, like sum up for the management of adnexal masses in pregnancy. So what you will find, most of the cases it will be simple cyst. If it is less than 5 centimeter, we are not worried. More than 5 centimeter, after 4 to 6 weeks, there will be rescan. And if it is same, still there, creating no problem, postnatally 6 weeks will cause again scan. On the other side, if there is low, if it is suspicion of cancer or intermediate, then investigation will be done, because in the pregnancy we can't leave it alone. Either we'll be doing tumor marker or we'll be doing MRI scan. If we are not worried for this cancer, so they will be we will see them again after 4 to 6 weeks time, then postnatally 6 weeks. High suspicion of cancer will go to surgery, MDT, onco MDT. Okay, so another simple way to learn is simple cyst more than 5 centimeter, complex cyst, intermediate type of mass. So they will be rescan after 4 to 6 weeks, and postnatal scan. So there will be two-way scan. Any suspicion for cancer will go for surgery or MGT. Okay. Now this what they have written. If in the malignancy is there in the pregnancy, so there would be MDT. Without onco MDT, nothing will be done. If CT scan is required with abdominal shielding, it will be done. If you find a scenario where the patient is in first trimester, then with the discussion, even consideration for termination can be done, because the treatment has to be started for malignancy. Now, if, as another type of question or scenario where you see the patient and the pregnancy is advanced, late second trimester, third trimester, then after steroid, early surgery by cesarean section can be done and the treatment will be started. So primary surgery, usually if the surgery is done in the pregnancy, so what surgery will be done? It will be unilateral salpingophractomy, surgical staging, cytology, omentectomy, peritoneal biopsy, and appendixectomy if it is abnormal, but it is not adequate surgery, that we already know. So once the baby delivery is done, then consideration for like CT scan, restaging, or laparoscopic assessment will be done, because complete evaluation cannot be done during pregnancy. So it will be extra ovarian disease cannot be assessed during pregnancy. For that, consideration for repeat surgery or restaging can be done. So if they do laparoscopy in pregnancy, either it will be Palmer or open technique, and these are the pressures. 12 to 15 are the pressure they are using. From this pressures I have already seen a question, and this also and if the apart from this, they will do laparotomy. They're more why they're interested in doing laparotomy, because it will prevent cyst rupture, tumor cell dissemination, and port site metastasis. Incision will change with the gestation. Why? Because there is a change in the position of ovary, because as uterus grows up, ovaries, they will go up also. So in first trimester, incision will be suprapubic transverse or lower midline, okay, because uterus is below. And if the surgery is done in second or third trimester, later half of pregnancy, so it will be upper midline or paramidline or low midline. Okay, from this incision also I have seen a question. That's all I had to say. Any question, anyone? Any question? No question. Okay, this I'll be speaking very fast, because it is old talk, 2016, I think. Few tables is important, only few lines. So like if childhood cancer is there, so usually what is acute ovarian failure occurs. What is the definition? Loss of ovarian function within 5 years of cancer treatment is acute ovarian failure. Only this definition you have to know. And if the radiotherapy is given, what is a dose where ovarian failure will occur? It will be dose above 10 GY. Above 10 GY, ovarian failure will occur. And why? In which chemotherapy agent it is there? With the alkylating agent and procarbazine, because question also comes from all these parts. Okay, premature menopause can also occur. It occurs in 30% of the patients. Now these are the drugs that these are causing ovarian toxicity. So these are the so many drugs, but just remember cyclophosphamide, that is the alkylating agent, and procarbazine. Now effect of radiotherapy, there will be it will affect so many ways with the radiotherapy. Like centrally there will be gonadotropic hypogonadism, or there could be at the level of ovary there will be premature ovarian failure. At the level of uterus there will be usually vascular insufficiency, uterine growth impairment will occur. All these things will occur if the radiotherapy is there on the uterus. So development will not be done, will not be so good. The vascularity problem, vascular insufficiency will be there. There could be miscarriage, death, premature labor, low birth weight, and fetal malposition. So much can occur if the radiotherapy is given to this part. Sometime questions may come. So what are the strategy for preservation of reproductive tissue? If the young child, adolescent is going for any kind of cancer treatment, we would like to do something to preserve reproductive tissue. So what can be done? What they say, ovarian tissue cryopreservation, oocyte cryopreservation, or GnRH analog during chemotherapy. Okay. Similarly, post-puberty girl, ovarian tissue cryopreservation, oocyte cryopreservation, immature oocyte retrieval can be done, or there will be cryopreservation for oocyte. And if the male partner is there, then embryo will be created and embryo cryopreservation. So these are the few strategies like that can be done to preserve a reproductive tissue. Okay, so ovarian tissue cryopreservation, oocyte cryopreservation, and immature oocyte cryopreservation or embryo cryopreservation. This can be done. And what is we are using for cryopreservation? It is usually by vitrification. Okay, now I'll be asking you questions. So this is a question number 1. So 21-year-old woman, radiotherapy has been given as a part of cervical cancer. What is a fertility sparing treatment you will recommend for the best chance of future fertility for this woman? What should be done to give her best chances of future fertility? Embryo cryopreservation, IVM, oocyte freezing, oocyte vitrification, or ovarian cryopreservation?
Ma'am, oocyte vitrification?
Yes, oocyte vitrification is the answer. This is from the strategy question bank. Now, 22 years old with a chemotherapy as a for Hodgkin lymphoma, which class of chemotherapy causes future ovarian failure?
Alkylating agents.
So 55 years old woman with a chemotherapy of stage 3 ovarian carcinoma. Initial CA125 is 436. Post chemotherapy CA125 is 30 international unit per ml. What this level mean for ongoing treatment? Brachytherapy to be done.
No treatment is
Yes, no treatment is required because CA125 almost has come within the normal level. Okay. So which of the following is false with the colorectal cancer and the Lynch syndrome? Colorectal cancer is the most common lethal cancer seen in the Lynch carrier, number 1. Number 2, risk of colorectal depends on the gene and sex of the individual. Women have high penetrance and high risk of cancer. Colonoscopy detection is difficult because they arise in the flat adenoma, hard to detect. They arise very highly on the right side of colon.
Ma'am, is it women have a higher penetration than men, which means high risk of colorectal cancer?
Yes. So C is the answer because reverse is true. Men have high penetrance than women, and men have higher chances of colorectal cancer. So this I wanted to do just sum up from the link talk about the colorectal cancer. Therefore, I made this question. Okay, which of the following will increase chance of ovarian cancer?
Late menopause?
Yes, late menopause. So what could be the protective factors? So protective factor for ovarian cancer is OCP, pregnancy, sterilization, tubal ligation, or hysterectomy. Factor that increase the risk. These are the hereditary, nulliparity, first birth after age of 35, early menarche, late menopause. That means increase ovulation, increase the chance of ovarian cancer. So a 30-year-old has been referred to genetic clinic for counseling. Her sister has breast cancer and she has BRCA1. So what is her Lifetime risk of developing ovarian cancer.
And C, 30 to 60%, because it is 67, no? 63.
Usually according to the SIP, so BRCA1 is 63 and BRCA2 is 27. So answer should be some nearing 63. So this is the answer according to this. 20-year-old woman in emergency department. The surgeon performs laparoscopy. Registrar on call calls you to give incident large solid ovarian mass in right adnexal with papilla on the surface. There is fluid in the pelvis that seem normal. So what will be the single most appropriate next step?
Refer to the gynecological, no, refer to the cancer center.
Yes, refer to the cancer center because all these are the sign of these are they belong to M rule of cancer malignancy. So 58-year-old woman with distension of abdomen. For last 6 months, she has been referred to gynae clinic for ovarian cancer. Suspicion tumor marker CA125 2000, CEA 1.2, CA 19.9. So what will be the next step? CA 125 is very high. She is 50 years old. She has
Refer, ma'am,
graduated.
to the cancer center.
Refer to cancer center will be the answer.
CT will not be there.
Ma'am, first we have to do CT scan, then refer to the cancer center, no?
It is clinic.
If it is clinically, it appears. If clinically you think that it is a cancer, then it can be done. CT can be done first, or otherwise she will referred to a cancer center.
But CA125 is very high, and all the features, multilocular and all those features are there. So it's clinically malignancy only.
Clinically malignancy only. So
That flowchart shows first CT scan and then refer.
No,
see,
ma'am, I can clear that out.
if
Ma'am, this is not clinical feature. These are the markers. Clinical feature means by diagnosis that we are palpating and we get a lump, or she is complaining of pain, something like that. We can directly refer to the cancer center in two conditions. When the clinical scenario tells that it is a malignancy, and secondly, if the positive family history is there. If these two are not there, then we have to do the CT first, confirm it, and then we have to send to the cancer center. What I have understood by the guideline.
so doing whether the CT should be done or whether CT should not be done, or whether it will be done before and whether it will be done after. Actually, there is no clear guideline for that. Okay, so there is no clear, because I have shown you that picture diagnosis in the secondary care. In this in that like flow chart also, what they spoke, if clinical suspicion, consideration for CT abdomen and pelvis, and if it is indicated, consideration for CT thorax. Okay, so there is no clear guideline about it. So if they say next step, so on the clinical basis, if they think of like a distension and all, then direct on the clinical basis direct referral can be done. But if that strong clinical suspicion is not there, then consideration for CT will be done. But here, from their clinical history, that flow chart also I will show. The clinical history, like it is direct referral to the cancer can be done. Okay, so I'll show you that flow chart. I'll show you. That will come. Some green color flow chart is there. I have put it later on. So 39 years old woman in gynae clinic for pelvic pain, 2 years. She was treated for endometriosis with a laser ablation. USG scan 2 months ago showed ovarian cyst with a low level echo. CA125 is raised. So what should be, there is an internal septate also. So what should be done next?
Here we can go for CT scan, ma'am.
No,
For
MRI. Here it will be
Achha,
MRI. I will give
USG
you
is not very.
Yeah.
Right.
So here
Yeah.
CT, MRI, if we see a ovarian mass, and if we want to get a better idea or better picture, then we'll do MRI. This is written in the postmenopausal guideline also. So here the ovarian mass is there, so they want higher definition of that. So therefore MRI would be the answer. But in any other scenario, if we have to see whether there is a omentum involvement is there, lymph node are there, we are suspecting cancer, then CT scan would be the answer. So here it will be MRI. 28-year-old woman with symptoms of menorrhagia, no intermenstrual postcoital bleeding. Her pelvic examination is normal. Scan shows incidental cyst. CA125 is 15. Cervical smear is normal. What should be done?
Repeat scan is not necessary.
Yes, no,
Ma'am,
basic. Yes.
ma'am, in the previous question, she was already treated for endometriosis, and CA125 was not much higher. So can't it be the recurrence of endometriosis, and we can
Yes,
proceed with
yes.
the laparoscopic cystectomy?
No, but one time surgery has been done, so there could be
But it
possibility.
recurs, no? Endometriosis recurs.
Yeah, but you will do diagnosis also before, like directly. Why you want to go for another surgery? Before going for another surgery, for better definition of this consideration, for because they have given some internal septa also, so better definition for this before going for surgery, consideration for MRI can be done.
Okay, ma'am.
Okay, why
Mm.
one surgery has already been done, so unless you are now completely sure what could be the pathology, we will not take this patient for another surgery. Therefore, and you want better definition of ovarian mass, so answer is MRI. Got it?
Okay. Yes, ma'am.
Okay, yeah, this we have done. So here there is no problem. It is simple. Say CA125 is normal. We want her nothing to be done basically. So nothing to be done is not an answer. So repeat scan is not necessary is the answer. Okay, 50 years old woman, 2 ultrasound scan. Current one has simple cyst of 3 to 4 centimeter. Previous one was done 4 months back. That has cyst of 5 into 4 centimeters. CA125 is fine. This is asymptomatic and well. What to be done?
K, repeat the transvaginal ultrasonography later on after.
So if you follow this chart, this is the chart from the postmenopausal guideline. So if a cyst was there and the rescan was done, on the rescan, if it is persistent, that means it is there. So it is one condition. If it is persistent, you will repeat her scan after 4 to 6 weeks. So from second part, the answer comes K. So these are like a histopathology question. If the signet ring cells there on histology, so what you will think of?
Signet ring cells.
H.
What is H?
Involves.
Krukenberg. Yes, so this is just sum up of it. So in granulosa cell tumor, Karl-Exner body or coffee bean is present. In endodermal sinus, Schiller-Duval body is there. Hilus cell tumor ring crystal is there. Serous epithelial tumor cymoma body is there. Brenner tumor Walther cell rest is there. Krukenberg signet cell is there. Clear cell tumor Hobnell cells are there. This germinolymphocyte is there. Teratoma, so many things are there. Okay, so this will help you in answering. So transitional cell epithelium from Wolffian remnant, what could be the tumor I just told now?
Brenner tumor, ma'am.
Yes, it is Brenner. It is Brenner. So Brenner tumor histologically there are island of transitional epithelium or wall-third nest in a compact fibrous stroma, look like coffee bean. Okay, look like coffee bean. So this is Brenner tumor. So low malignant tumor potential with no stromal invasion.
Borderline ovarian tumor.
Yeah, borderline.
Borderline.
Yeah. Mullerian aneurysm with Mullerian or origin tumor with poor prognosis. Clear cell. Clear cell has poor prognosis. Usually seen in postmenopausal women with fibroma thecoma. Okay, mixed syndrome. So it is thecoma. I just spoke. It is fibroma thecoma syndrome. Okay. "60-year-old woman with sudden onset pain, last 24 hours. She has been well, 2 vaginal birth, 20 years back, examined to found a right ovarian cyst. What could be initial assessment of this woman?"
Ma'am, B, pelvic ultrasound and CA125.
Yes. Now GPC, a 59-year postmenopausal woman with lower abdomen pain. GP examines and suspect a mass. In what condition she should refer to specialty services?
Ma'am,
What require?
Ma'am,
Yeah.
E, ma'am.
Yes, mass with fixed nodularity. A child. What should be the reliable measure of current assessing ovarian function in childhood survivor of cancer treatment?
Anti-Mullerian.
AMH. That is from that TOG of childhood survivor.
Okay.
So a 17-year-old woman, girl with primary amenorrhea, all investigation done. After that, a cycle hormones are given, but there is no withdrawal bleed. Why there is no withdrawal bleed?
Uterine function compromised by the treatment, ma'am.
Yes, uterine fibrosis. Endometrium is at fault. Uterine fibrosis.
Ma'am, why? Can you please explain? I generally get confused in the stage 1, stage 2, and stage 3 ovarian failure. Why can't it be the higher one?
Because see, all the tests are done. So various investigations are performed, which is considered adequate. That means all the test what they have done. That means hormonal test were well. There is no problem with hormonal test. So that means there is like FSH, LH, E2, prolactin, thyroid, all are normal. After that, they are giving them hormone. So if all tests are normal and so hormones are given, but uterus is not responding, then there is no withdrawal bleed. So it cannot be hypo or hyper or anything. They has to give some hormone value. So they usually when a patient come in our clinics also and all the hormones are normal, we give them withdrawal. So if their uterus is fine, they will have withdrawal bleeding. But if in spite of normal hormones, no withdrawal bleed, that means endometrium is at fault.
Okay, ma'am.
Okay, a woman underwent for gynecological cancer admitted with bowel obstruction. What is the type of cancer?
Epithelial ovarian cancer.
Yes, epithelial ovarian cancer. Bowel obstructions are common in recurrent epithelial bowel cancer. This is a flow chart for bowel obstruction in ovarian cancer. So I don't think the questions have. I just put it here, but the questions are not. I have not seen question from here. What is 5-year survival of ovarian cancer in UK?
5-year survival. Ma'am, 50 to 60%.
So 5 years. So now this is the chart that shows 1 year survival is 71 to 77, 71 to 7%. 5 year survival is 42.6. Okay. So just remember these numbers. Okay. And this is 10-year survival also they have given. 10-year survival also they have given. So just remember this 5-year survival for ovarian cancer is 42.6%, and this is from the Cancer Research UK. What is the main cause of death in epithelial cancer?
Bowel obstruction and its complication.
Yes. So most of the patient with recurrent ovarian cancer and bowel obstruction die from the complication of bowel obstruction. Okay. This is the line from TOG. 65-year-old in the gynae clinic with suspicious mass. Mass is 12 into 12 centimeter. What will be the single effective way of evaluating this mass?
Ma'am, is it
C, ma'am.
Mm-hmm.
CA 125 and TVS, ma'am.
120. It is 12 centimeter with the
Oh,
US.
then
Yes, you can't see.
okay, ma'am. Then
MRI?
transabdominal.
Both.
Both A.
Now you see this is the line from guideline. Transabdominal should not be used in isolation. It should be used to provide supplementary information in TVS, especially when the scan is cyst is large or beyond field of view of transvaginal USG scan. Those who do USG scan, they will be able to understand when they will put probe inside, they'll be able to just see cyst only. No measurement can be done because it will not come in the field of vaginal probe. So you have to put abdominal probe over the abdomen to measure the size. So answer will be TS and TVS. People who are doing a scan will be able to understand more. Okay, so now you have to calculate RMI here. So what is the calculation?
$450, ma'am.
Yes, so 450, and here is the calculation. Most common and lethal type of um, epithelial cancer.
A, ma'am.
Serous.
A, ma'am.
Serous.
Clear cell. Huh? Okay.
Basically, both are there. Clear and serous and clear both. But according to this talk, they wrote serous, but serous and clear both are bad. "25-year-old for genetic counseling. Her mother and sister both has ovarian cancer. She has been screened now. She has got BRCA1. What will be if the prophylactic sulfingofractomy is done? How much will be the reduction of ovarian cancer for her?"
42, 45. Ma'am, E?
Yes, E will be the answer because 80 to 96% risk decrease in the ovarian cancer. Okay, 80 to 96%. So they have not given that, so answer will be 80, but it is 80 to 96%. 50-year-old woman with debulking surgery has been done. What will be chemo plan?
E, ma'am. 6
What you
cycles.
say? What is the
Paclitaxel and carboplatin. 6 cycles,
yes,
ma'am.
yes. C is the answer. This I have spoken also. Paclitaxel, carboplatin, 6 cycle. 60 years old with a vague abdominal pain for ovarian cancer. She has been suspected for advanced disease, cannot be resected. She has liver metastasis also. What will be the best approach to this patient? Now this patient is presenting with liver metastasis. So this is very high stage or very high tumor burden. So what you will do?
D, ma'am.
D, ma'am. Neoadjuvant.
Yes. So it is very high tumor bulk, new adjuvant chemo by surgery, interval surgery. So 60 years old woman with TVS was done. TVS shows unilocular cyst. Asymptomatic, what will be the next?
CA 125.
Transabdominal and CA125.
CA120. Yes. So 59-year-old woman referred by GP, suggestive of irritable bowel syndrome. Medical treatment is ineffective. She has family history of cancer. What should be next step?
I, ma'am. Measure CA 125.
Here clinical symptoms are there. So on the basis of clinical symptom, he can examine and refer. So this is the table that you have to learn. So now women present to the GP. So if any of these symptoms are there, or if like this thing is there, physical examination identifies mass, urgent referral can be done. Okay, but from this then it will be CA 125 should come because she has got IBS symptoms. So if you follow this pathway, then CA 125 has to be measured. Okay, CA 125 has to be measured. So this should be the answer. But the book wrote full physical examination. Now if you see it here, so full physical examination is also comes here. Full physical examination is also comes here, but they are not giving, apart from this, like women present with unexpected weight loss, fatigue, change in bowel habit, ovarian cancer suspected. Yes, then CA 125. So instead of physical examination, in my opinion, so book writes the physical examination, but in my opinion, it should be CA 125 according to this flow chart. So what do you guys are thinking? In my opinion, it will not be full physical examination. It will be CA 125 if we follow this chart. So this is a detection in the primary care. So this it usually helps to answer your question. So now if the patient is coming to GP, they have put it in 4 categories. So if these symptoms are there or IBS is there, so they had to do CA 125. If it is more than it, so they will arrange scan, suspicion of cancer, urgently referral. And if if the value comes less, then GP will think that there could be another possibility or it will be referred back. Okay, apart from this, if any of these symptoms, unexplained weight loss, fatigue, change in the habit, ovarian cancer is suspected, then measure CA 125. These are the condition where urgent referral is done. Physical examination identifies. So here the GP has in this question, if we go to this question, she is presenting with the irritable bowel syndrome. So we have to follow this part of the pathway. So she is coming with the irritable bowel symptoms. So next step will be CA 125. But any of the scenario comes where they give physical examination finding, and this physical examination finding are this much finding is given. He has got suspicion of cancer, then urgent referral is done. Is it clear now? book answer was confusing. Is it clear? Referral pathway?
Yes, ma'am.
Yeah, because it creates a chaos. So you have to understand this pathway because answer will come from here only.
Ma'am, what is the source of that table, blue colored table?
Blue color table. You know, there is a quick reference, nice pathway for ovarian cancer was there. So this table, I took it from there, but it was there in my own notes. Right now, now I searched, but I was not able to get it. So from my days when I used to, get confused in this question, then this table helped me. So I had this table, but right now, if you, now I won't be able to send it. Like, because right now I'm not finding. They have changed
Yeah,
now what
actually,
white
I have seen also.
Yeah, white tables right now. If you search the internet, nice ovarian cancer. In the previously, I have shown you white flow charts. Right now, on the internet, that white flow charts are there. This was there previously, but this helps in answering questions, so I put it here in the explanation. Okay, now
Okay.
60 years old woman, suspicion of cancer, suspicion of what? Pelvic mass, vague symptoms, CA125, 365. Scan shows complex cyst. What will be the next step? Now you in this question, just understand you are getting some hint there could be possibility of CA because you are having suspicion. It is only suspicion of cancer. So what will be your next step?
CT, ma'am.
Yes. So if the clinical picture or ultrasonographic tumor marker malignant disease suspected, that means if the suspicion is there, then CT scan of abdomen and pelvis and onward referral to the gynae onco team is done. This question, already had come in the exam. So you have to remember this part very well. Okay, so now 80-year-old woman, 1 year ago, she has 40 millimeter cyst. She remained asymptomatic. Again, she had cyst. Cyst remains unchanged. So what you will do? Unchanged cyst. That means persistent cyst. Persistent cyst is there, so what you will do? Anything?
Reassure and discharge from follow.
No, for persistent, you
No,
will do
we
one.
should do surgery, but lab cystectomy option is not there. Lab BSO option is not there.
Yes, so if it, no, this is from this, if it is persistent or unchanged, so you have to individualize the treatment. Either it is from this part, center part we are doing, here because 2 scans has already been done. In the 2 scan, it is persistent. So repeat scan. After that, there will be, another discussion with the woman, what to be done. So if you see this part, now they have done, one time they have diagnosed it here. So patient was, so one scan was done here for the diagnosis. So they followed her up. So these are the 2 scans has been done, but the cyst is still there. So you will do repeat scan. So after 2 scan from this table, after 2 scan, if it is still persistent, so there is one repeat scan, then individualize the treatment. This scan was done here. So this scan was diagnosing. So this is diagnostic scan, this is repeat scan, and after this scan, repeat scan also, it is still there. Then again they are doing scan. Same way this question shows 2 times scan has been done. 1 time and 2 time. So 2 times scan has been done and it is unchanged. So 1 time scan done, 2 times scan done, unchanged. So answer is this. Appears to be quite confusing, but if you see it whole, then the things become easy. From this guideline, all the all answers will come from here only. All answers will come here only. In this guideline, this is very important. So whenever a postmenopausal ovarian cyst more than 1 centimeter, so measure CA 125, do TATVS. Here they have written both. Calculate RMI. If it is more than 200, it is risk of malignancy. So MDT review. Low risk can be managed by trained gynecologist. High risk will be oncologist. And for the, if it is less than 200, then if a patient has got any it is non-simple, more than 5 centimeter, multilocular, bilateral, then bilateral oophorectomy. And if it is single cyst, no symptoms, less than 5 centimeter, one loculi and unilateral, then this is a diagnostic scan. They'll do repeat scan 4 to 6 months. In second scan it is unchanged, so they'll do repeat scan. After that, individualization of treatment will be done. If it is resolved after 2 scan, 1 scan and 2 scan, so she'll be discharged. But if any change in symptom or anything, then intervention. Intervention will be bilateral oophorectomy. Okay, so now from each option, now you have to do the staging. So this is a 45-year-old woman. She has 6 into 6 centimeter cyst, CA 125 to 40, unilateral tumor with intact capsule. Okay, intact capsule, no secondary on surface of tumor, omentum, pelvic or abdominal retropelvic lymph nodes are there. Peritoneal washings are negative. TH, BSO, infracolic omentectomy has been done. Tumor was well differentiated serous cyst adenoma. What is the stage?
1A, ma'am.
Yes. Yes, it is 1A. Because one tumor, one ovary involved and capsule intact. So now see, this is the FIGO staging. So 1A, tumor to one ovary, capsule is there. 2B, tumor to both ovaries, capsule there. But C for C, capsule gone. So it is again divided into 3. If it is surgeon mistake, 1C1. If it is ruptured before we did surgery, 2. Peritoneal washing positive, 1C3. Okay, this is stage 1. Stage 2, extension to ovary fallopian tube, but it is below the brim. It is below the brim. Okay, so 2A and B. 2A is UTO implants. Uterus, fallopian tube or ovary UTO implants, and 2B will be extension to other organs. Okay, you will get question from here also. This is stage 3. In stage 3, tumor has gone outside the pelvis. If it is outside, then we are dealing with the stage 3. So stage 1, 2, this stage is microscopic. Till here it is microscopic. We can see under the microscope only. Under the microscope. If we can see with our eyes, so it will be 3B only. 3B onwards, we can see it from our naked eyes. So 3B less than 2 centimeter and 3C more than 2 centimeter. This way you have to remember 3B onwards, macroscopic. B is less than 2 centimeter, C is more than 2 centimeter. Stage 4 everybody knows. 4A is lung involvement. 4B is parenchyma of liver and spleen. Apart from this, inguinal lymph nodes are involved. Inguinal lymph node ovarian cancer is 4B. Question will come from here only. So you read this question and answer. Anyone answering?
I'm 2A, ma'am.
Very good, 2A, because UTO, uterus, tubes and ovary implants is 2A. So 39-year-old with abdominal pain of 2-week duration, previously mild, not requiring analgesia. She's mother of 2. GP requested scan. Simple cyst. What to be done?
Reassure.
Very good. Less than 5 cent. If it is a premenopausal woman, less than 5 centimeter, do nothing. These are physiological, resolve in 3-month time. Now she has a complex cyst. What you will do next?
Ultrasound scan, ma'am. Q.
Scan is already done.
Annual, ma'am. Annual ultrasound.
That is for simple cyst. Here it is complex.
Complex. Okay. Okay.
So less than 40, what you will do?
The tumor markers, ma'am.
Yes, tumor marker. Less than, if it is a complex cyst,
DH.
less than 40,
Hmm.
tumor marker. So it is 6 centimeter simple cyst.
Mhm.
CA 125, 150. What to be done?
This is only yearly scan, ma'am.
Annual
Yearly ultrasound.
Yearly ultrasound.
It should be yearly. But they have given CA 125 value also. That is 150. So if in the question, now you understand, if in the question CA 125 value is not written, answer will be yearly scan. But if they have given CA 125, 150, then you have to do further investigation. This is the question, this is the line from the guideline. CA 125 is raised, less than 200. Further investigation would be required. So what will be the further investigation? What we do for cyst?
Further
What we do?
investigation is MRCOG, but here CA 125 is less than 200.
Yeah, it is raised. It is raised than normal, but less than 200. So further investigation. So answer is,
But in question, CA 125 is 150 only. And RMI will also come low because she must be premenopausal, so score 1, left simple cyst. So score will be, means RMI will come below 200.
yeah, see, if the RMI is more, then gynae-oncology referral is required. So what they say, if the serum, there are two types of situation here. If CA 125 is not given in this question, then your answer will become yearly ultrasound Q. But if they have given CA 125 value, according to guideline, if it is raised, so it is raised. What is the normal? It is, so it is raised only, but it is less than 200. So further investigation has to be done. And further investigation for ovarian mass is MRI only. Is it clear?
Yes, ma'am.
If they remove this line, answer will be yearly ultrasound. Got it? If they remove this line, answer will be yearly ultrasound. Clear?
Yes, ma'am.
Now 70 centimeter cyst, vague lower pain, and CA 125 250. What you will do?
MRI.
She's having pain also. Symptomatic. What is the?
Refer to gynae.
She's having pain, complex cyst, CA 125 high. So gynae referral. Sorry, onco referral. So this is the summary. If asymptomatic, this is for the premenopausal woman. If asymptomatic simple cyst, less than, now this is for asymptomatic, less than 5 centimeter, we will not do anything, no follow-up, reassurance, because it is physiological, resolve in 3 months time. If asymptomatic cyst, there is no symptoms, it is 5 to 7 centimeter yearly USG. If it is more than 7 centimeter, if this cyst is more than 7 centimeter, consideration for MRI or surgery. This is for the asymptomatic cyst, according to guideline. And if you find a patient with a complex cyst, then tumor protein has to be done, tumor marker. If they have added CA 125 in the question, if CA 125 value is less than 200, then guideline writes for further investigation. Scan has been done, further investigation will be MRI only. If CA 125 value they have given and it is more than 200 they have given, so it will be gynae oncology opinion. So if you see this question here, she is 42 years, she has 70 centimeter cyst, CA 125 is 250. So basically this woman would require, so in a view that this woman requires, she has got symptom, so you have to treat this woman. So treatment will be laparoscopic, most probably cystectomy, but they have given this CA 125 values also. Therefore, answer becomes gynae oncology referral. So two things you have to understand here. If they give you the same question and CA 125 is not written, your answer will be laparoscopic cystectomy. E will be the answer. If 7 centimeters is pain, two findings they gave. But if they have added the CA 125 in the picture, your answer changes. Now, if it is more than 200, gynecology oncology opinion is required. Is it clear? Is it clear?
Yes, ma'am.
Okay. So whenever you do a question, always see whether only scan finding is given or additional CA 125 is given. If additional CA 125 is given, so your answer will change. This is from the guideline only. Too much big question. So now they want to ask you 5-year survival. Okay, now I'll be just speaking. So this patient, she has got one cyst. Contralateral ovary is normal, no invasion of capsule. So one side and no invasion of capsule. So what is the stage? 1A. 1A is the stage. And what is the survival for 1A? If you don't know, I'll just.
Should be around more than 80%, I guess.
So this is from the Cancer Research UK. Okay, so this is the 5-year survival, stage 1, 2, 3, and 4 for ovarian. So it is 95, 70, 25 and 15. 1, 2, 3, 4. So in our patient, it will be 95. So C, look for 95. So this is L is 95. So answer will be L. Okay. This you have to remember only. Now this is a 10-year survival. 10-year survival is 35%. 10-year survival is 35%. Okay. This number you have to remember. Questions start coming from here. These days, 1-year survival is also coming. So ovarian cancer, 1-year survival 71%, 5-year survival 42%, 10-year survival 35%. And this is the survival with the stages 1, 2, 3, and 4 of 95, 70, 25, and 15. This all data is from Cancer Research UK. Now you can see here the tumor is breached by the capsule is breached by the tumor. So what could be the staging? It will be
C2,
One C.
1 C2.
no, I
1
think here
C2, ma'am. Ma'am, 1
okay.
C2, ma'am.
Unilateral ovarian tumor extended to fallopian tube is involved.
Oh. Then 2A, ma'am.
2A, yes. And 2 we read 70%. Okay, so answer should be 70%. Okay.
Yes, ma'am. I 62 centimeters.
Okay. Few questions are left. It is becoming very long. So these are the options. So big options. So 64-year-old woman with simple cyst 6 months ago was asymptomatic. Now the measurement is done. Previous scan, ultrasound scan measurement is this. Now it is increased. This is third scan. And there is increase in reading from the CA125. So what should be done? So 3 times scan has been done. Still it is there.
BSO, ma'am.
Yes. So it should be BSO. Yes, laparoscopic oophorectomy is the answer. So 66-year-old woman with a suspected right cyst, sided cyst, 10 centimeter cyst, mural nodule, septation, vascularity, everything is there. CT scan did not show any secondary. CA125 is 78. So what to be done?
Laparotomy.
Laparotomy, yes. It should be surgical staging. So if you calculate RMI, so it will be more than, it is 702, more than 200 malignancy risk. So answer will be, and there is no secondaries. That means it is early stage cancer only. So surgical staging is the answer. Now another woman, so she is 70 years old with the symptoms of irritable bowel syndrome. Scan shows some partly solid, some partly cystic area. CA125 is this means CT scan shows no secondaries. What to be done? Similar kind of question. Answer is same, okay? Staging laparotomy only. "28-year-old woman, she is having a beta HCG injection 3 days prior to presentation. Okay, she is on ovulation induction. Left iliac fossa pain, UPT weakly positive. Ultrasound scan shows small cystic mass with spider web. Spider web is hyperstimulated ovary, okay? Not possible to separate from ovary. So small cystic structure, not able to separate from the ovary. What you will do? What you will do for this patient? She is presenting with what?
Analgesics and supportive. A.
Yes,
Yes.
analgesia and support.
Yes, analgesia and supportive. This is stimulated ovary, and follow-up scan will be done later on for pregnancy location. So now she is 28-year-old. She has intermittent pain. Okay, for 3 days, nausea, vomiting. Now settled. She antibiotic painkiller were given, but right now okay. Leukocytosis temperature is 37.6. What you will do? What is suggestive of? What it is suggestive of? Intermittent pain. What is suggestive of? Torsion. What is the treatment for torsion?
Detorsion, ma'am.
Yes, detorsion and cystectomy later on. So L is the answer. Now the 28-year-old woman, she has nausea, vomiting, now paraxial, and she is having well-defined mass. Dermoid cyst. What will be the answer for dermoid cyst?
Surgery, laparoscopic cystectomy.
Yes, laparoscopic cystectomy is the answer. So 38-year-old woman with a loss of appetite, weight loss for 6 months. Her mother died of ovarian cancer. GP performed the test, CA125. I think we have done this 267. Multiloculated cyst, some fluid of 1 centimeter. CT scan, no enlarged lymph node. What to be the treatment?
Surgical staging.
Very good. So RMI is very high, so answer will be surgical staging. Okay, now I'm just about to finish. So what is the feature of borderline ovarian tumor?
Absence of invasion,
Absence of
ma'am.
stromal A.
Yes, this is the answer. Few things you have to know about borderline ovarian tumor. So borderline ovarian tumor, they have increased mitotic activity, varying degrees of atypia, but their characteristic, they lack stromal invasion. Lack of stromal invasion. These are the type. Serous is the commonest. What could be the treatment for borderline ovarian tumor? So this is a treatment flow chart, because it is a very old talk, but it helps in answering, because if the borderline question comes. So borderline ovarian tumor, referral to a cancer center. If she is desirous of fertility, conservative surgery will be done. But if a patient has advanced stage, or if no desires of fertility, so complete surgery will be done. And this is the complete surgery. Okay, TH, BSO, appendixectomy in mucinous. Here lymph nodes are not removed. Okay, lymph nodes they are not removing or assessing also. Usually this question also has come, if the frozen section are sent, then 1/3 of the cases reported as borderline tumor in frozen section. Now if you are doing surgery and your pathologist says that yes, it is borderline tumor, later on in 1/3 of the cases it will come as invasive tumor. The question has come from this line, so I put it here. Okay, 40 years old woman with bloating and abdominal pain. Mother died of ovarian cancer. Genetic testing reveals BRCA1. So what her management should include all except what? What should not be done?
Breast screening.
Breast screening is done. Mammography.
Ma'am, that alone, ma'am. Oh, then screening for ovarian cancer, ma'am.
Yes.
Sorry, ma'am.
No, screening for ovarian cancer is not done. Why it is not done? Because there is no studies to support it is there. Usually to screen ovarian cancer you will do TVS or CA125, but according to the studies available, it is not sufficient for the screening. It will not be able to completely get it. So there is no method for screening of ovarian cancer. Okay, so our risk reduction is done, mastectomy is done, Angela Jolie. Breast screening with a mammography is done. and primary peritoneal cancer 1 to 6% is left. So answer becomes C only. Okay, that's all for it. So
Thank
any
you, ma'am.
question? Okay, thank you for joining the class. So anyone of you have got any question can ask me. Any question?
Ma'am, please take a class on module 1, that all that stuff of clinical governance and all.
Okay, I'll try whatever it is possible. But next class, I think it will be on menopause.
Okay.
Okay, all the best, guys. Bye.